Thank you very much, Adam, for this nice and kind introduction and for the kind introduction to speak today on the topic of neonatal brain imaging. And of course, it's a very large topic. So today we're going to focus on some aspects of normal development that we can see on imaging of the neonatal brain, as well as going to discuss some common acute diagnosis. I don't have any disclosures related to this talk. And just to give a quick overview of this lecture, we're just going to start with discussion of normal neonatal brain imaging appearance. And after that, we're going to spend some time discussing hypoxic ischemic injury. We'll talk a little bit about some imaging aspects of the neonatal stroke. We'll take a look at some perinatally acquired infections, and we're going to wrap up this lecture with a brief discussion of the metabolic disorders that can present in the neonatal period. But first, before we start, let's just discuss the overall what is the definition of the neonatal period and some other clinical aspects that may be pertinent to the imaging diagnosis of the pathologist during this period. So first of all, the definition of the neonatal period is the first 28 days of life. And for the baby to be considered term, they need to be born between 37 weeks and up to less than 42 weeks. So those that are born before 37 weeks of gestation will be considered preterm neonates, and those that are born at 42 weeks or later will be considered post-term neonates. In terms of the other things that it's important just to keep in mind is that in the neonatal period, acute neurological processes often going to present with the clinical combination of symptoms that's known as neonatal encephalopathy, which basically represents a variety of different clinical signs and symptoms, which commonly include difficulty breathing, abnormal tone. It may include depression of reflexes, feeding difficulties, and seizures is a very common presentation in this period. And overall, although the terminology that often used to describe this acute clinical state can be imprecise, it has been suggested that when there are some very clear clinical indications that the etiology for this acute process can be of hypoxic or ischemic, that's when the term hypoxic ischemic encephalopathy will be used. And the term neonatal encephalopathy is generally reserved for instances in which the definitive etiological diagnosis of the acute neurological condition is not known. So what are other things that are important for us to know before we even start discussing the imaging? And of course, clinical history is a big part of it. Obviously, clinical history is important always when we read imaging studies, but it's particularly important when we try to read a neonatal MRI or CTs. And what are some aspects of the clinical history that will be helpful for us? So first of all, of course, is gestational age at birth, because it's going to be affecting a lot of imaging aspects. For example, it will be predictive, or could be predictive of the pattern of hypoxic ischemic injury that we can see. Another very important piece of the clinical history is timing of clinical symptoms onset. For example, when we're talking about hypoxic ischemic injury, the clinical presentation usually happens within the first few hours after birth. If we're dealing with the cases where the onset of acute clinical symptoms happen later, like days or even weeks after birth, that should raise concern for alternative etiologies, which may be metabolic, infectious, or something else. It's also helpful to understand some specifics of the clinical course. For example, such details as delivery history, Apgar scores, Did the baby had a need for resuscitation? Was there decreased cord arterial pH level? Was there any respiratory or the multi-organ failure? And other clinical findings such as hypoglycemia or hyperbilirubinemia. Another important clinical piece of information is also a time lag between the clinical insult and brain MRI. And it's really important to understand that part and know that part because it can affect the imaging appearance of the intracranial findings, including normalization due to this time lag, as well as any treatment that has been already started. For example, very often we see babies with HA after already therapeutic hypothermia has been initiated, and that decrease extent and severity of some lesions that we can see in the basal ganglia or thalami. Another piece of clinical information that can be related to the treatment that has been administered may be related, for example, to TPN, which can mimic kernicterus because it can produce this intrinsic T1 hyperintense signal in the globus pallidus. So overall, having all this information just at the end of the day will just help us to a little bit better understand the imaging findings that we're going to see on MRI or CT. Okay, with that, let's just transition to the discussion of what is the expected normal appearance of the neonatal brain on imaging. And with that, I just wanted to start with this graph that really nicely shows very dynamic changes that happen in the neonatal brain composition. So when we look at the neonatal brain and as a preterm baby, usually the neonatal brain begins as a highly hydrated structure, and it has in the preterm brain has more than approximately 90% water by volume, which you can see on this graph depicted in this light blue line. And then subsequently, as the neonatal brain progresses towards the term, you can see that this dotted line represents the point of birth. There will be very rapid changes in terms of the content of the water within the brain, which is going to be dropping approximately 15 to 20% by the time of a term birth, and associated rapid increase in brain structural components, such as cholesterol, for example, which is depicted on this graph in the dark blue line, or others such as galactocerebrosides. And all those components, they just basically get integrated into the developing myelin of the cerebral white matter. And altogether, this is just important to keep in mind because these microstructural brain tissue changes, they underline the dynamic changes that we see on MRI during normal brain development. So if we take a look at and compare images of the neonatal brain to an older child, and here you can see on the left-hand side, we have T1 weighted images. On the right-hand side, we have T2 weighted images. And for each of them, we have a set of images of a 5 days old and a 5 years old. And as you can see, the neonatal brain has this inverted appearance in terms of the gray and white matter signal intensities, which is compared to the older child, which is related to the fact that initial T1 and T2 values of white and gray matter of the neonatal brain, they're higher than those of the older children and adults. And then along the course of the first 2 years, eventually the developing brain gonna obtain the appearance that we see in older children and adults. One thing that I just wanted to also quickly mention on this slide is that despite the fact that we see this inverted appearance in terms of the signal characteristics of the white matter and gray matter, important fact is that we always still should be able to see gray-white matter differentiation in the neonatal brain, as well as preservation of all CSF spaces like cerebral sulci and ventricles. So that still should be visible on all sequences. In terms of the progression of myelination, it usually, not usually, it always proceeds in a very predetermined pattern and follows this sequences where myelination proceeds from central to peripheral aspects of the white matter, as well as from caudal to rostral, from the posterior to anterior, and then if we're looking the sensory pathways, they precede myelination of the sensory pathways, precede myelination of the motor pathways as well. So there are multiple atlases of brain myelination, which are very helpful, just as in terms of correlation of the normal expected progression of the myelination. But just as a general rule, just to understand what are the parts of the brain that we expect to have myelination at the time of birth. And those include the dorsal brainstem, ventrolateral thalami, the posterior limb of the internal capsule, central coronary radiata, as well as perirolandic areas. Another thing that I just wanted to spend a little bit of time here is just to scrutinize the area of the basal ganglia, because this area will be really important when we will be talking about hypoxic ischemic injury. So a couple of things here. So first of all, if we really zoom in into the area of the basal ganglia, you can see here depicted by the orange arrow that we see this focal area of hyperintensity on T1 weighted images, which we should always see in the posterior limb of the internal capsule. And if you take a look and compare it to the adjacent posterolateral putamen, the signal intensity of this focus of hyperintensity should be higher, relatively higher compared to the posterolateral putamen. Another helpful imaging findings is also the fact that ventrolateral thalami and medial globi pallidi should also have higher signal intensity compared to other deep gray matter nuclei at this age. When we're looking at the normal brain myelination at birth on T2 weighted images, we're basically going to see very similar pattern of myelinated white matter, with the only difference is that myelinated white matter on T2 going to demonstrate T2 hypointense signal, comparing to intrinsic T1 hyperintense signal on T1. But the distribution of the anatomic structures, again, showing early myelination will be the same, including dorsal brainstem, ventrolateral thalami, posterior limb of the internal capsule, central coronary radiata, and perirolandic area as well. Similarly, if we scrutinize the area of the basal ganglia and posterior limb of the internal capsule, in a normal neonatal brain, we should always see a similar focus now of hypointense signal in the posterior limb of the internal capsule, as well as adjacent ventrolateral thalami. Also, we should see some focus of hypointensity is nearly always seen as a curvilinear area in the far lateral putamina and claustra on T2 as well. Finally, because of all the specifics of the neonatal brain, of course, CT appearance also has its own specifics. For example, the unmyelinated white matter will demonstrate this really diffuse hypodensity. However, we still should be able to appreciate some gray-white matter differentiation. Another imaging findings that we pretty consistently see on CT images of the neonatal brain is a really marked hyperdensity of the vascular structures, which is related to the physiologically high hematocrit that we see in babies that are just born. Another thing that we can also see on CT images of the neonates is findings related to the process of birth and delivery. And those may include skull molding, small posterior subdural hematomas, as we can see on this coronal image, as well as a variety of extracranial collections related to the birth process. Okay, well, hopefully this was helpful, just brief discussion and reminder of the normal appearance of the neonatal brain. And with that, I think now we're ready to transition to the discussion of our first topic, which is hypoxic ischemic injury. And to start with, again, as I already mentioned earlier, so hypoxic ischemic encephalopathy is a clinical diagnosis, which is basically made on the basis of a constellation of clinical findings, in which it may include presence of profound acidosis in baby, or Apgar scores at birth, presence of seizures, hypotonia, multi-organ dysfunction. So let's just spend a few minutes very briefly discussing what exactly is happening. What's the pathophysiology of hypoxic ischemic injury, hypoxic ischemic encephalopathy, as we currently understand it. And to begin with, both hypoxia and ischemia, whether occurring in isolation or in combination, ultimately results in the lack of energy substrates that are needed to power normal cellular functions and processes. And you can see this depicted on this graph as like deep in this blue defined level of the metabolic substrates. So in the neonatal hypoxic ischemic encephalopathy, this immediate situation has been labeled as a primary energy failure. So, and one of the earliest, so if we correlate what's happening during this period with what can be depicted by on imaging. So one of the earliest events which can potentially be detected by imaging is the presence of anaerobic metabolism during this primary energy failure period. Because what happens in the absence of sufficient oxygen, cells are going to transition to less energetically efficient anaerobic metabolism. And one of the byproducts of this type of metabolism is accumulation of lactate. So as you can see on this graph on the far right, you can see that MR spectroscopy is actually one of the most earliest MR imaging modalities that allows us to detect that increase in the lactate, which can be seen within the first 24 hours of primary energy failure. Another, just a pathophysiologic component that happens during the phase of primary energy failure is cytotoxic edema. And of course, we can pick that up using diffusion weighted images. And again, as you can see on this graph, that DWI can start showing abnormality in the brain pretty early, pretty much during just following the MR spectroscopy, starting within the first 24 hours. So during this period of primary energy failure, we can see that what happens with the cell, it's basically they undergo the process of immediate cell death or cell necrosis. However, that's not the only process that's potentially can happen. So if this situation of energy deficiency continues, then after a latent phase, we're gonna transition into the secondary phase or secondary energy failure. And this phase is characterized by another mode of cellular death, which is called apoptosis. So basically, at that point, we're going to have a combination of inflammatory processes as well as programmed and unprogrammed cellular death. And the therapeutic hypothermia, the window for application of this treatment is usually during this latent phase with the goal to reduce the processes of the secondary energy failure. Okay, so just quickly, a very quick thing about another important, two important concepts that are applicable to hypoxic ischemic injury is the concept of maturational cellular vulnerability as well as regional distribution of susceptible cellular components. And basically, those two concepts, they mean the following, that in terms of the maturational cellular vulnerability is that different cellular groups, they have different sensitivity to the injury that happens during hypoxic ischemic injury. For example, it's known that in preterm infants, they are especially susceptible to white matter injury. And in preterm infants, it has been demonstrated, for example, that lethality of immature pre-myelinating oligodendrocytes is much, much higher compared to the lethality of mature, more mature cells when they are subjected to the same level of hypoxic ischemic injury. So basically, the extent of injury is going to be greater if the same amount of injury is applied at earlier stages of brain development compared to later stages. In terms of the regional distribution of susceptible cellular components, the illustration, the example is going to be known fact, for example, that immature pre-myelinating oligodendrocytes are the majority component of the cerebral white matter in preterm infants. And that's one of the factors contributing to predominantly white matter injury in preterm infants compared to term infants, where it's hypothesized that the tendency to predominant injury to the gray matter is, at least in part, is related to dense glutamatergic innervation of the basal ganglia, thalami, and cortex in term neonates. So if we look at this all concepts in a little bit more simplified way, in terms of how can we apply that to the imaging of the hypoxic ischemic injury. So basically, the imaging pattern that we can see will depend on a brain maturity at the time of the insult, as well as a couple of other factors, including duration of hypoperfusion happening during the time of insult, severity of that hypoperfusion, which altogether in combination going to define imaging patterns that we can see. And of course, this is a more simplified approach, but in general, we can define several patterns depending on combination of these factors. So if we take a look at the severity and duration of hypoxic or ischemic event, so if we talk, it can be acute or prolonged. And then in terms of the severity, it can be mild to moderate or severe. So overall, during the childbirth, it's really common to have short periods of mild to moderate hypoxia or ischemia, and they usually never result in any significant brain injury. So in order for mild to moderate brain injury to result in mild to moderate hypoxia or ischemia to result in brain injury, it needs to be prolonged enough, which usually means between 15 to 25 minutes, or that hypoxia or ischemia needs to be severe. And in that case, the pattern will be different depending if we're talking about short or more prolonged intervals of severe hypoxia or ischemia. So with that, let's just take a look and see how this is going to present itself on brain MRI. So first of all, if we are talking about prolonged and mild to moderate reduction in cerebral perfusion or hypoxia, we can see what's known as a peripheral pattern of hypoxic ischemic injury on imaging. And that will be presented in term neonate that presents with involvement of the cortex and subcortical white matter, as we can see in this four days old who presented with seizures and low initial Apgar scores, where on DWI you can see those areas in the watershed distribution involving the cortex and subcortical white matter. In term neonates, we also known that there is a predilection to greater involvement of the parietal occipital and posterior temporal lobes compared to anterior regions. While in preterm neonate, the same pattern of hypoxia or ischemia will predominantly affect the periventricular white matter. If we transition to a severe reduction in cerebral perfusion or hypoxia, uh, however, of short duration, that results in what's known as a central or basal ganglia thalami pattern of hypoxic ischemic injury. And what happens during this process is that injury happens to the most metabolically active areas. And in term neonates, that's going to be thalami, basal ganglia, corticospinal tracts, and hippocampi, while in preterm neonates that can involve, in addition to thalami, also superior vermis and dorsal brain stem. So how are we going to see that on brain MRI? So first of all, DWI, of course, plays an important role in assessment of the central pattern of hypoxic ischemic injury. And it's important to keep in mind that DWI may be falsely a negative, or it may underestimate injury within the first few hours. Another thing to keep in mind that if we're only looking at DWI images, the findings may be subtle because there is a pretty high T2 signal of unmyelinated white matter, which basically means that we really always need to correlate appearance on DWI with the ADC maps, because ADC values will remain decreased by approximately 30 to 50%. I apologize. Let me just let my cat out because she really doesn't want to stay here. Just one second. Okay, now we can continue. Okay, and finally, pseudonormalization of findings on diffusion-weighted images happens approximately at the end of the first week after the insult. So what else can we see in the central pattern of hypoxic ischemic injury? Another findings that we can see on T1 weighted images will be related to the development of this abnormal hyperintensity, which we see in the basal ganglia and thalami. And typically we see development of this signal abnormality somewhere between day 3 and 7, as in this example of a 7 days old who is now status post therapeutic hypothermia, and we can appreciate the abnormal hyperintense signal within the basal ganglia in this case. Another thing that we can see on T1 weighted images is known as an absent posterior limb sign, which basically what happens is that focal area of T1 hyperintense signal that I was talking earlier that you can appreciate on this image on the right that shows the normal appearance of basal ganglia on T1. It becomes obscured because now we have this abnormal hyperintense signal involving basal ganglia and thalami, and we really can't appreciate that focal area of hyperintensity in the posterior limb as well as we should in the normal brain MRI. In terms of the findings on T2 weighted images at this period, usually what we see is early on, somewhere day 1, we may not see any or just see very minimal T2 signal changes. And finally, by day 2 or 3, we will start seeing this increased signal in the basal ganglia and thalami with indistinct appearance of the structures in that area, including the focal area of hypointensity that's normally expected in the posterior limb of the internal capsule on T2 weighted images. And finally, the third pattern that we can see is the total brain injury, which basically means that there has been a prolonged and severe reduction in cerebral perfusion or hypoxia. And in this case, we can see really diffuse injury to cortical, deep gray matter structures, as well as white matter structures. And this is known as a white cerebrum sign, which basically, like we can see in this example of a full-term neonate who had a history of prolonged delivery and later developed refractory seizures. And where we can see on DWI, there is really uniform abnormal restricted diffusion throughout the both supratentorial cerebral hemispheres involving cortex and white matter and deep gray matter nuclei. In this pattern of brain injury and hypoxic ischemic injury, aside from findings on DWI, on T1 and T2 weighted images, we're going to see loss of gray-white matter differentiation and really diffuse effacement of CSF spaces, like in this example, where on both T1 weighted images, we can see this abnormal diffuse T1 intrinsic hyperintense signal within the basal ganglia, and then both T1 and T2 show really loss of any gray-white matter differentiation. We can appreciate cerebral sulci, and really both lateral ventricles, they're super tiny and slit-like related to all the mass effect that's happening in the intracranial compartment. So in conclusion, if we again take a look at this graph that I showed earlier, so overall, the findings of hypoxic ischemic injury on MRI, they're usually more conspicuous between days 3 and 5, because this is that time window when we can appreciate those changes on pretty much DWI, T1, T2 weighted images, as well as on MR spectroscopy if we are performing it. Okay, with that, I think we can now transition to our next topic that we will be discussing, and that's neonatal stroke. So with neonatal stroke, again, first, let's just define some terminology. And in terms of the overall, the perinatal stroke can be divided into several groups. So first group is what's known as a fetal stroke. And basically this is a stroke that happens between 18 gestational weeks up till delivery and labor. The next group that we're gonna see in the perinatal stroke is the neonatal stroke, and this is the stroke that is confirmed that happens between the birth and the first 28 days of life. And finally, there is also the term that's used, presumed perinatal stroke, when the stroke is identified after the 28 days of life, but it presumed to happen during the perinatal period. And overall, the percentage of stroke that we see during this perinatal period is actually quite high, because approximately 1/4 of all childhood strokes occur during the perinatal period, which is not a small number. So let's just take a look a little bit closer at what exactly we can see in this group of disorders. So first of all, similar to adults, we can divide all perinatal stroke into arterial and venous in terms of its etiology. So if we're looking into the subgroup of arterial perinatal stroke, this includes 4 separate entities, including neonatal arterial ischemic stroke, presumed arterial perinatal ischemic stroke, hemorrhagic and presumed hemorrhagic stroke. And then in the subgroup of venous perinatal stroke, we can see perinatal periventricular venous infarction, as well as cerebral venous sinus thrombosis. So now let's just take a look a little bit closer at some of those specific strokes. So first of all, arterial ischemic strokes. And in terms of what is the risk factor for development of arterial ischemic stroke in neonates, a good percentage of those cases, up to 1/5 of them, actually never have any identifiable risk factors. So we basically really don't know why the stroke happens. However, there are some known risk factors that predispose or increase risk of arterial ischemic stroke developing, which include intrapartum fever, presence of preeclampsia, use of instrumentation, emergency C-section, resuscitation at birth. And it is thought that all those risk factors, they basically exacerbate pre-existing hypercoagulable state of pregnancy, and they lead eventually to thrombus formation. So if we're looking at the arterial ischemic stroke, more than 50% of them occur in the MCA territory, and there is a predilection for strokes to develop more on the left compared to the right, which is thought to be related to the existing right to left shunts, such as, for example, patent foramen ovale. If we, basal ganglia or thalami perforator strokes, they're more commonly seen in difficult deliveries or in babies who have sepsis. And then also there can be involvement of multiple territories if we're dealing on babies with meningitis or cases of embolism or thrombophilia. And this is on the left, you can just see the example of a large left MCA territory stroke in a 6 days old neonate with meconium aspiration syndrome and presentation with seizures. And as you can see at the time when we see this already completed stroke, on MRI, we really don't see any associated significant vascular narrowing or occlusion, though in a 30–40% of those cases, these findings can be present in vascular imaging as well. So in terms of the hemorrhagic stroke, again, there is a multitude of risk factors, and major causes of hemorrhagic stroke in this age group usually includes germinal matrix hemorrhage in preterm babies, as well as sinus thrombosis, underlying vascular malformations, coagulopathy, and hemorrhagic conversion of ischemic infarct. Other factors related again to more difficult delivery, they considered as a possible additional risk factors for development of intracranial hemorrhage in neonates as well. So here, this is just an example of a term neonate who presented with multifocal both infratentorial and supratentorial hemorrhages that was thought related to hemorrhagic disease of the newborn due to vitamin K deficiency in this case. And I just wanted to bring your attention to the hemorrhages that we see supratentorially, because it just, this is based on their location and appearance, even though we have only CT, that just makes us think that those hemorrhages may be subpeel in location. And I just wanted to spend a minute talking about this particular type of hemorrhage, because we not uncommonly see it in neonates and infants, and that's not a type of hemorrhage that we see in older children or adults. So it's really important to be familiar with the concept of this hemorrhage and its imaging appearance. So here on this nice diagram from the AJR paper, we can just take a look closer at where this subpeel hemorrhage is exactly located. And as you can see illustrated on this diagram, the blood collects underneath the really very closely adherent pia mater, which is depicted here in green. And the subpeel hemorrhage, it basically gets collected between the pia mater and the cortex of the underlying brain parenchyma, which basically leads to the development of a very local compartment syndrome and may result in mass effect, as well as development of parenchymal edema and restricted diffusion within the subjacent brain parenchyma. Okay, now we can transition further to the neonatal venous thrombosis. And again, similar to arterial strokes, pediatric venous infarcts are really most common in the neonatal period. So up to 40% of pediatric venous infarcts are seen during this period. And when we're talking about dural sinus thrombosis, even though the imaging findings of sinus thrombosis is going to be similar to adults and neonates, non-contrast CT diagnosis can really be challenging because, as we already discussed, there is this intrinsic hyperdensity of vascular structures in the neonatal brain, which makes this diagnosis more challenging. when should we start thinking about a possibility of venous thrombosis is when we see unexplained hemorrhage or we see unexplained parenchymal injury that does not meet arterial vascular distribution. And then infarcts in the territory of the thrombosed venous structures also can provide some clues in terms of which venous structures can be involved. Like, for example, parasagittal location will be seen in the thrombosis of the superior sagittal sinus, temporal hematomas in cases of transverse sinus thrombosis, or thalamic hemorrhages in case of vein of Galen and straight sinus thrombosis. And this is just an example of a dural sinus thrombosis in a term neonate who presented with sepsis. And as we can see on first two images, which are non-contrast CT had, there is a small amount of intraventricular hemorrhage and very tiny amount of hemorrhage in the thalamus, as well as hyperdensity of both superior sagittal sinus as well as a straight sinus and vein of Galen. But again, it's really challenging to definitively call it a sinus thrombosis, or at least say that it's concerning for that just on non-contrast CT due to, again, like normally hyperdense appearance of those structures in neonates. And that's why obtaining a venogram, like in this case, CT venogram was obtained that nicely demonstrated the filling defect within the superior sagittal sinus is really helpful to confirm this diagnosis. Just a few words about medullary vein thrombosis, because this is a known distinct pattern of perinatal venous stroke. And it's important to keep in mind that in neonates, medullary vein thrombosis can occur in the absence of cerebral sinovenous thrombosis. So here we can see medullary vein thrombosis in a preterm neonate with bacteremia and meningitis. And it has a very characteristic appearance in SWI with this brush or hyperintense vessel sign, which basically represents prominent engorged medullary veins on SWI. And they have a very characteristic fan-shaped branching pattern that we can see on SWI, and corresponding to that also can be fan-shaped configuration of the restricted diffusion and hemorrhage, which is known as an iris sign. So, and accompanied to that, as in this case, we can see pretty extensive parenchymal vasogenic or cytotoxic edema combination of both, as well as hemorrhage. And location of the involved medullary vein also kind of predict the location of the associated hemorrhage. For example, if we're talking about deep medullary vein thrombosis, we're going to see more intraventricular hemorrhage with that, while subpial hemorrhage can be seen in cases of superficial medullary vein engorgement or thrombosis. Okay, now let's just transition to the discussion of some cases of perinatally acquired infection. We're not going to be talking about congenitally acquired infection, which is another big topic on its own. And here we're just going to discuss a few acute infections that we can see in the neonatal period. So first of all, when we're talking about bacterial meningoencephalitis, usually the clinical presentation is going to be more so related to the generalized symptoms of having sepsis in a newborn, because typical signs and symptoms of meningitis that we can see in older children, they really very subtle in neonates. And when we're talking about the major causes of bacterial meningoencephalitis in this age group, it's going to be primarily group B streptococcus and E. coli. So if we take a look, both of them, they can be divided into two groups. One of them is going to be early onset disease, which presents during the first week of life. And in this group of bacterial meningoencephalitis, it's primarily 80% of GBS infections going to present during this first week of life, an early period. In this group, even though we have the majority of the infections happening during this period, meningitis complicates not a very large percentage of cases and is seen in approximately 10%. And then there is what's known as a late onset disease, which happens during the first first through the fourth weeks of life. And it's a minority of this infection. However, it has a much higher rate of meningitis complication, which can happen up to 40–60% of cases. So what are the imaging findings that we can see? And it's really a really broad spectrum of findings that we can appreciate. So first of all, of course, it's going to be presence of meningitis and cerebritis with variable contrast enhancement. Like you can see on this example on the left, this is a 22 days old with a group B strep meningoencephalitis and ventriculitis. And we can see multifocal areas of restricted diffusion, both extraaxially as well as involving the superficial cortex, subcortical white matter with associated edema. And other findings that we can see is ventriculitis, development of ependymal contrast enhancement, and ventricular debris, which may demonstrate restricted diffusion, as in our case. Other findings may include subdural effusion and empyemas, associated vasculitis, as well as related to that dural vena, as well as dural sinus thrombosis or cortical vein thrombosis, and related to that arterial and venous infarction. So overall, of course, a very large spectrum of manifestations that we can see intracranially in this group of disorders. Another acquired infection that I just wanted to briefly mention is related to paracovirus or enterovirus infection. And this infection, they really, in terms of their clinical and imaging manifestation, they have very similar presentation. So that's why we're going to be discussing them at the same time. And they can be acquired even prior to delivery, though the majority of the cases actually happens following delivery. And it usually takes approximately 1–2 weeks following perinatal transmission for the disease to actually start presenting some clinical symptoms. And in terms of some clinical symptoms that can be seen with these viruses, they again very non-specific, like fever and irritability, though they may have associated diarrhea and rash, which may provide some clinical clues into what the causing agent could be. However, when we're looking on the MRI appearance of encephalitis related to these viruses, they have a very distinct pattern of the restricted diffusion, which characteristically likes to involve frontoparietal white matter along the course of the deep medullary veins, as well as involvement of the corpus callosum and thalami, as we can appreciate in this case. And usually, for some reason, these viruses, they really tend to spare basal ganglia, brainstem, and cerebellum. A few words about herpes encephalitis. Of course, we all know that it's a highly lethal, so about approximately 50% of cases will have lethality related to this encephalitis. And the majority of the transmission, it happens peripartum, and only a smaller percentage of cases can be transmitted either postnatally or in utero. So when we're looking at the imaging presentation of encephalitis caused by herpes virus, there are some features which are actually different from what we normally expect to see in adult cases of HSV encephalitis. And those features include, first of all, more diffuse involvement of the brain parenchyma. Like you can appreciate in this brain MRI of a 2-week-old neonate with herpes encephalitis, where we can see really pretty diffuse involvement of the both cerebral hemispheres, involving both cortex, white matter, and gray matter structures. Another important thing to keep in mind is that the typical locations that we think of in terms of the herpes encephalitis, such as, for example, medial temporal lobe or inferior frontal lobe, they may be spared. And DWI is really very helpful in those cases because HSV tends to have early DWI abnormality. And again, another thing that is different compared to adult herpes encephalitis is that hemorrhagic changes is uncommon compared to adult manifestation, but they still can develop later. So overall, it's just really important to keep this encephalitis in mind. And when you see any restricted diffusion in a neonate presenting with infectious symptoms like fever, at least to mention that, just because the consequences can be quite severe. And this is just a follow-up of that case that we just saw in a prior slide. And you can see how extensive the brain parenchyma gets affected. So in a 2-year follow-up brain MRI, we really see this extensive areas of cystic encephalomalacia pretty much in all the areas of the brain that were involved initially. Okay, and in the last, we have what looks like 9 minutes. We're going to just briefly talk about some metabolic disorders that can present in the neonatal period. And we're going to start with the hypoglycemia because it's actually the most common metabolic disturbance in neonates. There are a couple of interesting things about hypoglycemia. And first of all, the ability of a neonate to tolerate hypoglycemia is inversely proportional to the degree of their maturity. So basically, if we take a look at the whole spectrum between less mature neonates to more mature neonates and older children, so the older children get their ability to tolerate hypoglycemia gonna be going lower compared to less mature neonates. Another interesting thing about hypoglycemia is that in order to result in brain injury, we really need to have a prolonged and severe hypoglycemia. However, it's important to keep in mind that effects of hypoglycemia will be exacerbated when in combination with hypoxic ischemic injury. So basically, on its own, mild hypoglycemia or mild hypoxia or ischemia usually does not result in any brain injury. However, if we put them together, they gonna result, they have a potential to result in brain injury, which will have the pattern of hypoxic ischemic injury plus involvement of the corticospinal tracts. So what are the regions of the brain that are particularly susceptible to injury due to hypoglycemia? And the most severe is, of course, occipital and parietal lobes, like we can see in this example of a term neonate who was born to a mother with history of maternal diabetes and presented with refractory seizures. And we can see really symmetric, extensive areas of restricted diffusion involving bilateral occipital and parietal lobes. Other areas of the brain that also can be affected include hippocampi, caudates, putamen, brainstem, and cerebellum. A few words about inherited metabolic disorders. And there is, under the umbrella of inherited metabolic disorders, which is a huge group, there is a subgroup known as devastating metabolic disorders. And those metabolic disorders, they have presentation in early neonatal period. And they have a profound severity usually of the metabolic abnormality compared to cases with later presentation, and as such can really have a very rapid clinical deterioration, meaning that they necessitate very rapid diagnosis and rapid therapeutic measures. So just examples of devastating metabolic disorders may include maple syrup urine disease, or, for example, non-ketotic hyperglycemia, among others. And then what's the role of imaging in all this? So first of all, of course, neuroimaging findings in this group are often non-specific and can overlap with multiple other types of brain injuries. So primary goals of imaging in this group is going to be to characterize the pattern of brain injury, suggest the possibility of an inherited area of metabolism, provide differential diagnosis with other types of brain injury, as well as identify life-threatening complications, and also using imaging for treatment monitoring. So let's take a look at one of the examples of these disorders, which is maple syrup urine disease. And this is a disorder with impaired metabolism of the brain's chained amino acids, and it preferentially involves the myelinating and myelinated white matter. And here on the left, you see the CT images of a 15 days old full-term neonate who developed profound metabolic acidosis and was first got the CT done at the outside hospital. And you can really appreciate that there is really very diffuse hypodensity involving both supratentorial and infratentorial white matter. And then if we transition to MRI, so in this disorder, we have a very typical intramyelinic edema, which demonstrates restricted diffusion, particularly affecting the myelinating and myelinated white matter, including deep cerebellar white matter, corticospinal tracts, thalami and globi pallidi, and with associated T2 hyperintense signal, and also associated vasogenic edema. And finally, MR spectroscopy also can be helpful in these cases as it shows this broad peak at 0.9 ppm. Another devastating metabolic disorder that we can see in this group is a non-ketotic hyperglycemia. This is a disorder with the defect in mitochondrial glycine breakage system. And again, there is a predilection to involve the myelinated white matter. Another things that can be present on imaging is structural brain abnormalities. And one of the most common is going to be dysgenesis of the corpus callosum in this group. So here's the example of brain MRI of a 7 days old full-term neonate presented with some poor feeding and hypothermia. And we can see areas of symmetric restricted diffusion involving the internal capsule, central tegmental tracts, with corresponding T2 hyperintense signal in the involved areas. And again, MR spectroscopy this case may demonstrate a glycine peak, which we can see at 3.56 ppm, just helping to further suggest this specific metabolic abnormality. So in conclusion, just to wrap it up, it's important to understand the normal imaging appearance of the neonatal brain. It's really very important to have a thorough understanding of the clinical history of what's going on with the baby. In terms of the most common acute diagnoses that we have discussed and that most common to be encountered, those include hypoxic ischemic injury, perinatal stroke, and different types of infection. And finally, consider possibility of a metabolic disorder when that is suggested by history and or imaging findings. And with that, I would like to thank you all for your attention.
Well, thank you so much, Anna, for that incredible talk. Definitely a tough topic, and I think you really touched on all the the major points, and it was really incredible to see how easily you make it look to make all these diagnoses. If anybody,
Well, it's much easier to do than the presentation than in real life because yes, neonatal imaging stuff.
Yeah, if anybody has any questions, feel free to put it into the chat. But that was an incredible talk. So one question was, do you have any do you use adjusted values for MR spectroscopy in neonates?
So we just use the standardized values for MRS, and I don't believe that they're adjusted specifically for neonate. They are age adjusted. So yes.
Meaning that the spectroscopy looks different. A normal spectrum looks different in a neonate compared to an adult.
Of course. Yeah. Yes, of course. So yes, it's going to be age adjusted for that specific neonatal age group.
Yes. And the other question was about neonatal ultrasound. What do you look for in an ultrasound for in a neonate?
That's a very good question, and I should just start answering the question by saying that I personally do not read a neonatal ultrasound just because in our group it's done by general pediatric radiologists. I do look at all ultrasounds when I'm reading MRI, but I'm probably not the person to answer that question to the full extent. Of course, neonatal ultrasound is going to be very often the first modality used to image the brain, just because for multitude of reasons, including portability and lack of ionizing radiation. And I do think that it provides a pretty significant amount of information. For example, we can definitely evaluate for any kind of suspected intracranial hemorrhage and hydrocephalus and ischemic injury. But at the end of the day, I think it's a really good screening modality, after which we still, if there is persistent clinical concern and questions are not answered, it requires further evaluation with brain MRI at the end of the day, because there are a lot of other things that ultrasound may not evaluate well, or just miss, just solely because of the screening nature of this modality.
And then maybe one last question, not to take up too much time from everybody. Well, so what do you do when there's a history of hypoxia, but the MRI is normal? Do you put any disclaimers or anything in your reports, or what do you do with a normal MRI but a history of hypoxia?
I would say that in the majority of cases, I do not put a disclaimer. So I just usually read it the way it is. And if that brain MRI looks completely normal, I just read it as completely normal MRI. I think that I only may put a disclaimer in a cases where there is really very significant discrepancy between clinical history and MRI. For example, if they have history of really severe hypoxia, I don't know, there was some kind of like really extensive event going on during delivery, and they have a very high concern clinically, and clinically baby is not acting normally, but the MRI looks completely normal. I think that those are going to be the only circumstances when I may put a disclaimer that maybe we're within that time window where we just the imaging findings are obscured, and just obtaining follow-up MRI will be helpful to further evaluate. So I would say that that's probably the only scenario where I might put a disclaimer and recommend a follow-up. In the majority of cases, if MRI looks good and there is no significant discrepancy between the clinical course history and findings on MRI, in that case, I do not.
Okay. Do you have time for a couple more questions, or
Sure.
there's a couple. Yeah. So one is, how commonly do you do long TR, or I guess long T, MR spectroscopy to capture the glycine peak in the setting of the non-nucleotidic hypoglycemia?
If we have a clinical concern for that, we usually perform it. So we usually do it.
And then when do you recommend imaging for HIE? 3 to 7 days, question mark, or when would you recommend doing the
Well,
MRI?
like I mentioned during the presentation, so the best time to image it somewhere between 3 to 5 days. I think in many cases it's also just driven by the clinical course in hypothermia and other measures that they're doing. So often it's not so much when we would like to scan the baby, it's when the baby is ready to be scanned, when they're ready for MRI. But in terms of just like the best window for that, it's somewhere between 3 to 5 days.
Sounds great. And with that, thank you so much, everybody, for joining us in person for this wonderful talk. Thank you again, Anna, so much for this. It was really wonderful. I hope to see everybody here next month again for next Peanut Talk. And everybody have a great month.
Thank you.
Thanks.